In this section, we'll examine how the electrical events in the heart produce the cycle of contraction and relaxation. The contraction cycle is known as systole, which is where we have atrial or ventricular contraction. And diastole is the relaxation phase. Now we can say atrial systole or ventricular systole, but in general, if we're referring to it without reference to a particular cavity, systole would refer to ventricular contraction and diastole would refer to ventricular relaxation, as these are the most important parts of the heart for getting blood out into circulation. Now the sinus rhythm is set by the SA node, which sets the rhythm at about 60 to 100 beats per minute. At rest in an adult, it's normal between 70 and 80 beats per minute. Sometimes the SA node isn't working properly, and then we'll have an ectopic focus. That's where another part of the heart fires before the SA node. Sometimes an ectopic focus is caused by hypoxia, low oxygen, electrolyte imbalance, caffeine, nicotine, or other more potent stimulant drugs. Most often, if the SA node is not firing, we'll see an ectopic foci at the AV node. The AV node firing will bring the heart rate down to about 40 to 50 beats per minute. If the AV node doesn't fire, then the intrinsic ventricular rhythm will take over. This sets the heartbeat about 20 to 40 beats per minute. And that's why people would have a pacemaker installed to sustain life, because this is just too low of a rate to circulate enough blood. Arrhythmias are abnormal cardiac rhythms. There are several different varieties of arrhythmias. It's a failure of the conduction system to transmit signals, often caused by a heart block. You could have a bundle branch block, which is where the signal is blocked in one of the bundle branches due to death of tissue, and so the signal is not propagated properly through the ventricles. A total heart block is where there's damage to the AV node. A few of the arrhythmias we might see are atrial flutter, which is where we see an ectopic foci in the atria, which beats in addition to the SA node. This causes an atrial beat about 200 to 400 times per minute. There's also premature ventricular contractions, which are caused by stimulants, stress, or lack of sleep. Premature ventricular contractions are a result of premature firing of an ectopic focus. Ventricular fibrillation is a very dangerous situation. It's a serious arrhythmia caused by electrical signals reaching different regions of the ventricle at widely different times. The heart thus cannot pump blood out into circulation and receives no coronary perfusion. It's said to look like a bag of worms. The ventricles are just not contracting in unison and pushing blood out into the great vessels. It kills very quickly if it's not stopped. This is where we'll often see defibrillation used, which is a strong electrical shock. And the intent is to depolarize the entire myocardium, stop the fibrillation, and reset all the cardiocytes and the SA node to the sinus rhythm. So why does the SA node fire spontaneously at regular intervals? It's not like skeletal muscle in that there's not a stable resting membrane potential. The resting membrane potential of pacemaker drifts. It starts at about negative 70 millivolts and drifts upwards. This is a result of slow inflow of sodium, but no corresponding outflow of potassium. So the membrane potential drifts slowly towards negative 40. This gradual depolarization is called a pacemaker potential. When it reaches a threshold of negative 40 millivolts, the voltage-gated fast calcium and sodium channels open, and we'll see inflow of calcium and sodium, which brings the membrane potential more towards zero. Once this faster level of depolarization occurs, it peaks at about 0 millivolts. At this point, fast potassium outflow channels open. Potassium flows out and the membrane returns towards -60. Once the potassium channels close, the pacemaker potential starts over. Slow inflow channels are open and the pacemaker potential continues. Each depolarization of the SA node will set off one heartbeat. At rest, it fires about every 0.8 seconds, which results in a heart rate of about 75 beats per minute. So once the SA node is fired, it stimulates the two atria to contract simultaneously. The signal then reaches the AV node in about 50 milliseconds. At the AV node, the signal slows down. First of all, there are thinner cardiocytes, but they have fewer gap junctions. So the scenario is much like coming off an interstate into a small town. The speed limit drops. With fewer gap junctions, there's less propagation of signal. This will delay the signal about 100 milliseconds, which allows the ventricles plenty of time to fill. Without this delay, the ventricles wouldn't fill appropriately, and we wouldn't be delivering enough blood out into the system. The signal travels very quickly through the AV bundle and Purkinje fibers. This allows the entire ventricular myocardium to depolarize and contract in near unison. The papillary muscles contract an instant earlier than the rest. That allows tightening of the tendinous cords so that the valves can be held closed and they're not forced open backwards. As ventricular systole progresses up from the apex of the heart, we'll see the heart contract in sort of a twisting motion because of the spiral arrangement of the cardiocytes. It's much like someone wringing out a towel from the bottom up as the blood is forced out into the great vessels. This figure is to remind us how the signal is propagated from the SA node throughout the atria to the AV node and down through the bundle branches and into the Purkinje fibers. So we've examined how a pacemaker potential works. Now let's look at the potential of a regular cardiocyte. Cardiocytes are going to depolarize only when they're stimulated. They'll have a depolarization phase here, a plateau phase, and a repolarization phase. After stimulus, the voltage-gated sodium channels will open. The sodium inflow depolarizes the membrane and triggers the opening of more sodium channels in this positive feedback loop. Thus, we decrease membrane potential more and more rapidly. Sodium channels close when the cell reaches its depolarized state at positive 30 millivolts. And then we have this plateau phase. The plateau exists because slow calcium channels are allowing calcium to enter the cell. Because they're slow, it prolongs the depolarization of the membrane. It's also a positive charge moving into the cell, so we're maintaining this more negative state. Now, there's a slight decrease in the plateau because there's potassium channels, and potassium is rushing out of the cell. So the membrane potential drops slightly during this plateau phase because we've got calcium, positive charges moving into the cell, and we have potassium positive charges moving out. Slightly more potassium out is going to allow for this plateau to decrease. Calcium channels close at the end of plateau, and then calcium is going to be transported back out of the cell. Now the potassium channels are fully open, and rapid outflow of potassium is going to return the cell to resting potential. The reason that we need this plateau is so that we can have a sustained contraction of the cardiocyte in order to expel all the blood from the ventricles. Cardiocytes have a long absolute refractory period, about 250 milliseconds. The refractory period in skeletal muscle is only about 1 to 2 milliseconds. This is to prevent wave summation and tetanus, which would stop the pumping action of the heart. We want rhythmicity. We want the heart to keep pumping. We don't want a sustained contraction. This figure will help you walk through and understand what's going on in the action potential of a cardiocyte. This will be a great time to put your pen on your paper, diagram the action potential of a cardiocyte along with that of a pacemaker cell. Compare and contrast the differences. Perhaps even correlate them with a neuron action potential. So an electrocardiogram measures the composite of all action potentials of nodal and myocardial cells. It's amplified and then recorded by electrodes that are attached to the arms, leg, and chest. There are three principal portions that we'll look at in an ECG. Sometimes it's known as an EKG, K for cardio in German. We're going to examine the P wave, the QRS complex, and the T wave. The P wave is when the SA node fires and the atria depolarize and contract. Atrial systole begins about 100 milliseconds after the SA's signal. The QRS complex, here in the middle, is where we see ventricular depolarization. There's a complex shape of the spike due to different thicknesses and the shape of the two different ventricles. Ventricular systole begins shortly after the QRS complex in the ST segment. Atrial repolarization and diastole also are occurring during this QRS complex. The ST segment corresponds to the plateau in the myocardial action potential and thus represents the time during which the ventricles contract and eject blood. The T wave is ventricular repolarization and relaxation. The figure we've been looking at represents a normal electrocardiogram. A nice P wave, a little space, a QRS complex, and a T wave. We can characterize each of these different intervals, as we'll do shortly. When we look at the electrical activity of the myocardium, in conjunction with each of these phases, we can see the following. When we look at figure 1, the atrial depolarization is beginning. In number 2, the atrial depolarization is complete. That means the atria are completely contracted as we go up through the P wave. In the third image, ventricles begin to depolarize at the apex. The atria are repolarized as illustrated by the green, as in they're relaxed now. In 4, the ventricles are now depolarized completely. That means the ventricles are contracted and they are pushing blood out into the major vessels. In 5, we see the RS returning down as the ventricles begin to repolarize at the apex. By the time we finish the QRS complex and gone through T, the ventricles have completely repolarized. They're now relaxed, and the cycle will begin again. We can look at normal and abnormal ECGs and tell a lot about the state of someone's heart. Figure A shows a normal sinus rhythm. B shows the nodal rhythm when it's generated by the AV node. So there's an absence of an SA node. That means we don't see the P wave. Your textbook will show a few other cases. The point here is not for you to be able to diagnose by an ECG, but recognize that it's indicative of the state of someone's heart. It can illustrate abnormalities in conduction pathways. It can show that myocardial infarction or heart attack has happened. It can show that a heart is enlarged, or it can exhibit electrolyte and hormone imbalances. So take a moment now to diagram or outline for yourself what happens during each phase of the ECG. What's going on during P? what's going on during the QRS complex, and what's going on during the T wave. There's no need to get more complicated than that. And I'll see you soon for our next section where we look at blood flow, heart sounds, and the whole cardiac cycle.